My name is Paige Parliament, and I'm going to demonstrate how to properly perform a wound intake examination. Now, before we get started, let's just talk about the wound that we have here. It looks to be about 20% non-viable, 80% viable, and a deep partial thickness wound. Now, let's talk about the peri wound. My name is Paige Parliament, and I'm going to properly demonstrate how to perform a wound intake examination. I've already cleaned the wound, and after I clean the wound, I would doff, sanitize, and don a new pair of gloves. And before we get started, let's take a look at the cleaning field that I have here. We see some cotton applicators, my ruler, some syringes, and some gauze. All right, so let's just talk about the wound for a second. It looks to be about 20% non-viable, 80% viable tissue. And I would also say it's a deep partial thickness wound. Let's go on and talk about the peri wound. You can see some discoloration taking place, maybe black, maybe dark purple. That could be signs of hemosiderin staining. And then if we bring it around over here, we have white and shiny, and that could be signs of maceration. So after we discuss our peri wound, we're gonna take measurements on the wound. And before we do that, you see our wound edges are rolled up. Those are gonna be included in my measurements. So for the measurements, we're gonna use the clock method. 12 o'clock is going in the cranial direction, 6 o'clock in the caudal direction, 3 o'clock, and then 9 o'clock. So my first measurement will be my length. That's the longest part of the wound bed that we see. You can use 12 to 6 o'clock as your baseline, but in this case, you have to shift it over to the 11 to 4 o'clock direction because that's the longest part of the wound. We're gonna go ahead and measure. And I get 3.2 centimeters. Now going on to the width, that's gonna be the widest part of the base. And for this, it's gonna be the 3 to 9 o'clock direction. And I will measure. And by the looks of this printed out wound, it looks to be 2.2 centimeters in width. So after doing the width, we're gonna go on to the depth. I have my clean cotton applicator. I'm going to enter the wound entering perpendicular to the wound, and I'm going to probe the deepest part of the wound base that has viable tissue. And once I'm there, I'm gonna be close to the wound right here. I wanna be parallel to the wound base, and I want my thumb to slide down and be parallel to the wound edges. So after I probe it, I pull it out. I'll be using my ruler here to measure. And my depth comes out to 1.2 centimeters. So after doing that, I would discard my cotton applicator, get me a new cotton applicator, and I'm going to evaluate for any tunneling or undermining. So whenever I do that, I'm going to insert my cotton applicator perpendicular to the wound wall, and I'm just assessing the infill. So you can see I'm assessing right here. I'm assessing the infill and just feeling for it, utilizing my thumbnail. And then I would see that at about 5 o'clock, it looks to be some undermining taking place. And I would just kind of go in a side to side lateral direction. It's really hard to do this on the board, but we're gonna do it in a 5 to 6 o'clock direction. And then I would pull it out, measure. And that undermining is 1.2 centimeters. So then I would discard that applicator, give me another one. I'm gonna go in perpendicular to the wound wall, keep assessing for my infill, And I'm gonna be looking for tunneling, and it looks like in the 11 o'clock direction right here, that could be probable tunneling. You see right there. So that's it. I would keep assessing my infield, and I would see if the applicator sinks deeper and where to make sure it's still in that 11 o'clock direction. I would probe the tunnel in its infield and apply slight pressure to mark the end of it. So I would slide my thumb down, using that as my reference point, and then I would retrieve it, and then I would measure it. And that tunnel is 1.6 centimeters. All right, so then I would discard of that. And after getting my tunneling and my undermining, I would discard my applicator, debride, doff, sanitize, don a new pair of gloves, and then I would take the measurements again. Now let's discuss the etiology of this wound that we see. We have the location. It's the left medial lower extremity, just superior to the medial malleolus. The patient reports throbbing pain. We also have non-pitting edema. We also have an increased mid-calf girth on that left lower extremity. She presents a DVT of 0, which is low risk. Also has an ABI of 0.98, which we know the normal range is 0.9 to 1.1. She also has her sensation intact with the 5.07 monofilament testing, and she also has history of hypertension and hyperlipidemia. Now, when we tested her venous filling, it was less than 5 seconds. So with all of that, her throbbing pain, her edema, all of it, I'm going to differential diagnose this patient with venous insufficiency.